So let us discuss about the classification of malocclusion. The individual tooth malposition that refers to the deviation or the misalignment in the position of teeth concerning its neighboring teeth with the same dental arch. So these malposition they are known as intra-arch. So these can be of following type. The first is the mesial inclination or the tipping. So this is seen when the tooth it is angled or tilted in a way that its crown portion uh, it is mesial to the root. So suppose this one is the crown portion and this one is the root. So the crown would be tilted. The crown is mesial. So the crown is tilted mesial to the root. Whereas the distal inclination, when the tooth it is tilted distally, that means that the crown it is, so this crown it is tilted distally side as compared to the root portion, that is the distal inclination. Lingual inclination, the tooth is abnormality tilted toward the tongue or palatally. And labiobuccal inclination, when the tooth is inclinated toward the cheek. So these type of tooth malposition it can result from the various factors like the crowding habits like thumb sucking, abnormal jaw growth, or the trauma. Other can be infraocclusion. Infraocclusion means when, so this tooth is infraoccluded, it means when the tooth it is positioned below the level of the occlusion. So suppose this one is the occlusion level and tooth is below the normal level of occlusion plane, it is known as infraocclusion. The supraocclusion means it is the opposite of the infraocclusion. So these teeth, when the tooth it is above the level of occlusion plane, it is supraocclusion. Rotation refers to the movement of tooth around its long axis that leads to twisting or turned appearance of the tooth. It can be either mesolingual or distolabial rotation. When the mesial aspect of the tooth it is inclined lingually, and the distal aspect of crown it is labially placed. So that is mesiolingual or distolabial, and its opposite is distolingual or mesiolabial rotation. Now the malrelation of the dental arches. These malocclusions they are characterized by abnormal relation between the teeth of one dental arch to that of the other. So the interarch, remember the interarch malrelation, it can occur in three planes. One is sagittal, second is vertical, and other is the transverse plane. So sagittal means when there is a issue related in anterior posterior positioning of the upper and lower teeth. So the vertical plane malocclusion can lead to deep bite and open bite, whereas the transverse plane malocclusion can lead to scissor bite or the cross bite. So this plane is the sagittal plane. This one is the coronal plane, and this plane it is the transverse plane. So this plane is the coronal plane. This plane it's the sagittal one. Now the sagittal plane malocclusion can be of two types. They can be either pre-normal occlusion or post-normal occlusion. So post-normal occlusion is when the mandibular arch it is placed more posteriorly when teeth meet in the centric occlusion. That's the post-normal occlusion. Whereas when the mandibular dental arch it is placed more anteriorly when the teeth meet in centered occlusion, it is the pre-normal occlusion. Now the vertical plane malocclusion as discussed can be of two types, deep bite and the open bite. So this one is the deep bite, a patient with a deep bite. So there is excessive overlap of the upper teeth over the lower teeth. So when the jaws are closed, so that causes the lower teeth to bite into the roof of the mouth. And the open bite is when the teeth fail to make contact when the jaws are closed. So that leaves a gap in between upper and lower teeth. The transverse plane, it can be when the malocclusion is in the transverse direction. So this one was the transverse plane. So when it's the example is the crow's bite. So when the one or more teeth they are positioned inside the lower teeth instead of ideal outer position or the vice versa. So the abnormal transverse relation between upper and lower arches could be due to the crossbite. Now let us discuss the classification of malocclusion. It can be angle classification, Davis classification, Lissard, Simon, Bennett, Ackerman, Ballard, incisor classification, and the Kautz premolar classification. The first is the angle classification. The angle classification, it was given by the angle. So this angle classification, it is based upon the mesiodistal relation of teeth, dental arches and the jaw. So according to the angle, he considered the maxillary first permanent molar as the key for occlusion. He classified the malocclusion into class 1 malocclusion, class 2 malocclusion and class 3 malocclusion. The class 2 malocclusion can be subdivided into division 1, division 2 and subdivision. Whereas the class 3 malocclusion, it can be class 3, pseudo, class 3 or subdivision. Now the first malocclusion is the class 1 malocclusion. So here the mesiobuccal cusp of the maxillary first molar. So this cusp is the mesiobuccal cusp, occludes in the buccal groove. So this is the buccal groove. When the mesiobuccal cusp, it occludes in the mesiobuccal cusp of the maxillary first molar, it occludes in the buccal groove of the mandibular first molar. It's known as class 1 malocclusion. So malocclusion in class 1, it can be either crowding, spacing, rotation, missing teeth, etc. Bimaxillary protrusion, it is example where it's a normal class 1 molar relation, but both upper and lower dentition they are protruded in relation to the facial plane. Other is the angle class 2 oh, malocclusion. So here the distobuccal cusp. So this one is the mesiobuccal cusp. This one is the distobuccal cusp. So the distobuccal cusp, here it lies within the buccal groove of the mandibular first molar. That's the angle class 2 malocclusion. So it can be divided into division 1. Here you will see proclined upper incisors with increase overjet, that is the horizontal distance. A deep incisor overbite can occur in the anterior region. There could be presence of abnormal muscle activity. The upper lip, they are hypotonic. They fail to form a lip seal. The lower lip cushions the palatal surface of upper teeth that is known as lip trap. So this one is the lip trap. There are hypotonic, the upper lip. They are hypotonic. There are the upper incisors, they are proclined. There is increase in the overjet, that is the horizontal distance. Increase overjet, deep incisor overbite, abnormal muscle activity. So all these are feature of the class 2 malocclusion. Now the class 2 malocclusion can be division 1, division 2. Division 2, here you will see the lingually inclined upper central incisors. So these upper central incisors, they are lingually inclined. They are inclined toward the lingual side. And the lateral incisors, they are labally tipped, overlapping the central incisors. So these are labally tipped. So this one is the class 2 division. And class 2 subdivision, it's when the class 2 molar relation occur on the one side and class 1 relation on the other side. So in one side you will see class 2 molar relation, and on other side you will see class 1 relation. Here the mesiobuccal cusp, it would lie in the buccal groove, whereas the distobuccal cusp, it would lie in the of the maxillary molar, it would occlude in the mandibular groove. The other is the class 3 malocclusion. The mesiobuccal cusp of the maxillary first molar, it will occlude mesially to the buccal groove of the mandibular first molar. So here the mesiobuccal cusp of the maxillary first molar, it occludes in the interdental space between the mandibular first and second molar. It can be either divided into true class 3 or pseudo class 3. True class 3, it is generally of genetic origin. Here you will see excessive large mandible, forward placed mandible, that is smaller than the normal maxilla. The maxilla is smaller than the normal maxilla. There would be retro-positioned maxilla. So these are example of true class 3 malocclusion. Whereas the pseudo class 3, false or postural class 3, it is produced by the forward position movement of the mandible during the jaw closure. So that is why it is known as false or pseudo or postural or habitual class 3 malocclusion. It can be due to when there is presence of occlusal prematurity that may deflect the mandible forward and give rise to pseudo class 3. in case of premature loss of deciduous posterior and child with large enlarged adenoids. The class 3 subdivision, it is characterized by class 3 molar relation on one side, and other side you will see class 1. So class 3 on one side and class 2 on class 1 on other side. Now, what are the drawback of angle classification? The angle, he considered the malocclusion only in the anterior-posterior plane and not in the transverse or the vertical plane. He considered the first permanent molars as a fixed point in the skull, which is not entirely accurate because these teeth, they are not rigid or fixed entity. The third is the classification does not work well when the first permanent molars, they are missing or extracted. The classification cannot be applied to the deciduous dentition. It does not distinguish between malocclusion due to the skeleton discrepancy and those due to the dental misalignment. So the other is the classification does not highlight the etiology of malocclusion. And individual tooth malposition, they have not been considered by the angle. So these are the merits and demerits of the angle classification. Now the D way, he classified the class 1 into various 5 subtypes and class 3 malocclusion into the 3 subtypes. So class 1 malocclusion with crowded anterior teeth is type 1 D way classification. Type 2 is when there is class 1 malocclusion with protrusive maxillary incisors, when the maxillary incisors, they are protrusive. When there is anterior crossbite, that is type 3, as you can see here. Type 4 is when class 1 molar relation, when there is posterior crossbite. Class 5 when there is mesioversion of the molars due to early extraction of the second deciduous molar teeth. The class 3 malocclusion, he divided into 3 types. The type 1, when upper and lower dentition, when viewed separately, they are in normal alignment, but when the arches, they are made to occlude, the patient will show edge to edge incisor alignment. That would be due to the forward movement of the mandible. Type 2, when the mandibular incisors, they are crowded and in lingual relation to the maxillary incisors. And type 3 is when the maxillary incisors, they are crowded and in crossbite in relation to the mandibular interiors. Lisher, he divided malocclusion. He modified the angle classification. He gave neutroocclusion, that is angle class 1 malocclusion. Distocclusion is the angle class 2 malocclusion, and mesiocclusion is the angle class 3 malocclusion. Apart from that, he gave bucco-occlusion when there is buccal placement of tooth. Lingual occlusion when there is lingual placement of tooth or group of tooth. Supraocclusion when they are erupted beyond the normal level. Infraocclusion when they have erupted below the normal level. Mesioversion when they are placed mesial to normal position. Distoversion, distal to normal position. Transversion when there is transposition of teeth, like the canines and premolar. So suppose these are the canines and these are the premolars. So interchange in the position that 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 refers to transversion. Exversion is abnormal axis of inclination of tooth, and torsiversion is rotation of the tooth around its long axis. So torsiversion is rotation, whereas exversion is axial inclination. Now the Simon's classification, it is a craniometric classification. He classified into based on three planes, that is Frankfurt horizontal plane, orbital plane, and the mid sagittal plane. So this plane, it's the Frankfurt horizontal plane. So it connects the external auditory meters to the infraorbital margin. So this plane, it is used to classify malocclusion in the vertical plane. So when the dental arch or part it is closer than normal to the Frankfurt plane, it is attraction. And when it is away, when the dental arch or part it is away from the Frankfurt plane, it's the abstraction. Similarly, orbital plane, it is perpendicular to the FH plane. According to Simon's law, this plane should pass through the distal surface of upper canine. So suppose this one is the canine and this one is the distal surface. So this plane should pass through this the distal surface of the upper canine. So this plane, it is used to describe the malocclusion in sagittal or anterior posterior direction. Similarly, when the dental arch it is away from the orbital plane, it is protraction, and when it is closer, then it is retraction. So the mnemonic to remember is POR, orbital plane. When it is away from orbital plane, it's protraction, and when it is close, it's retraction. POR, it's the mnemonic. The mid-sagittal plane, that refers to malocclusion in the transverse direction. So when part of whole arch it is away, it's diffraction, and when it is near, it's called contraction. The mnemonic is DMC. The mid-sagittal plane, D is when it is away, it's the diffraction, and when it is near, it's known as contraction. And M is the mid-sagittal plane. Now the Ackermann-Profit classification, it is based upon three characteristics: alignment, profile, transverse relation, class, and by depth. The alignment, it focuses on how teeth align with each dental arch. So it will assess the symmetry and spacing, determine if the teeth they are aligned, ideally aligned, crowded, or spaced within, or spaced, whether there are gaps between the teeth or not. The second is the profile. It evaluates the shape of face from the side view, which can be categorized convex, straight, or concave. It also examines the forward and backward position of the face. Third is the transverse relation. It involves assessing the side to side relation of the teeth. So it examines both the skeleton and the dental relationship. The class, it refers to the sagittal relationship of teeth. Using the angle classification, they can be class 1, class 2, or class 3. So it helps to differentiate between the skeleton and dental malocclusion. The bite depth, uh, so it focuses on the malocclusion in the vertical plane, assessing the overlap or lack of overlap between upper and lower teeth. It includes the overbite, open bite, or posterior bite. So these are the 5 profit classification based upon alignment, profile, transfer relation, class, and bite depth. The other is the Ballard classification that 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 gave he gave 3 classification: class 1 incisors, class 2, and class 3 incisors. So this one is the class 1 incisors. When the lower incisor edge, they occlude below the cingulum of the upper central incisors. So when there is small gap between the upper and lower teeth, the lower teeth, they will touch the upper teeth along their length. The class 2 can be divided into in the class 1 relationship, the lower incisors occlude immediately below the cingulum, and in class 2, in the class 2, they can be divided into class 2 division 1 and class 2 division 2 incisor relationship, and other is the class 3 relationship. The lower in the class 3, the lower incisor edge will lie anterior to the cingulum plate of the upper incisors. So this one is the class 3. This one is class 2 division 1, and this one is the class 2 div 2. So in class 2 div 1, in the class 2, that is categorized into class 1, division 1, and division 2. In division 1, the upper central incisors, they are of average inclination or pro-inclined, and over that the horizontal distance would be increased. So the upper is pro-inclined and this horizontal distance would be increased. Whereas in div 2, the central incisors, they are retro-inclined. So the overjet is within the normal limit, and overbite it is increased. That is, the overbite is the horizontal distance. So overbite would be increased and overjet would be normal. The central incisors, they are upper central incisors here would be retro inclined, whereas they are pro inclined here. The cat's premolar classification. Other is the cat's premolar classification. That is premolar class 1, class 2, and class 3. Now the malocclusion, that refers to the misalignment of teeth or when there is incorrect relation between the teeth of the two dental arteries. Now the different classification has been proposed based upon the etiology of the malocclusion. They are: number 1 is the White and Gardiner classification. So this classification primarily focus on the genetic or hereditary factors. Second is salesman classification. Uh, Salesman classification includes the factor related to habit and environment. Other is Moyer classification. The Moyer classification, it is based upon, it considers the skeleton and dental discrepancy as the main cause of the malocclusion. And other is the Graeber's classification. The Graeber classification focus on the development cause and the issue related to the growth and development of the teeth and the jaws. The first is the White and Gardinger classification of malocclusion that aims to distinguish between the skeleton and dental etiological factors. So it categorizes the malocclusion based on dental base abnormalities, pre-eruptive abnormalities, and post-eruptive abnormalities. The first is the dental base abnormalities that could be due to the anterior-posterior malrelation, vertical malrelationship, or lateral malrelationship of the teeth. The lateral malrelation refers to the side-to-side positioning of the teeth or the jaws. Vertical means the irregularities in up and down alignment of the teeth. And anterior-posterior refers to the abnormalities in the front to back positioning of the teeth. Other are the pre-eruptive abnormalities that could be due to the abnormality in the position of the developing tooth germ. It also could be due to the absence of certain teeth that can impact the overall alignment of the dentition. Supernumerary teeth, extranumerary teeth, prolonged retention of the deciduous teeth, the delayed shedding of the deciduous teeth impact the eruption and alignment of the permanent teeth. A large labial frenum that can affect the dental alignment. Traumatic injuries can impact the development and alignment of the tooth. These all are considered in the pre-eruptive abnormalities. The post-eruptive abnormalities, that could be muscular activities abnormal or excessive forces exerted by the muscles. Improper resting position of the muscle leads to malocclusion. Persistent habits like thumb sucking or using pacifiers can impact the dental alignment. Irregularities in closing mouth. Abnormality in the path of closure that can affect the alignment. Early loss of the deciduous teeth before their natural shedding affect the eruption of the permanent teeth or the extraction of the permanent teeth. Other classification can be Salzman classification. He classified the factors according to the malocclusion into functional and environmental factors. The functional factors include the general functional factors that could be endocrine disturbances, neurotropic disturbances, nutrition deficiency, etc., or local functional factors like loss of teeth due to failure of the proximal contact between teeth, disturbance in TMJ articulation, hyperactivity of masticatory muscles, trauma, all are the local functional factors. The environmental factors could be either local environmental factors. The other is the Graeber classification of malocclusion. That includes the general factors. The general factors are the hereditary, or congenital. The environmental could be here could be prenatal and postnatal. Prenatal, during the pregnancy, such as trauma, maternal diet, germ measles. Postnatal factors after the birth, like birth injuries, cerebral palsies, and TMJ injuries, are considered in the postnatal period. There are factors that predisposing metabolic climate and disease, that could be the climate factors, uh, endocrine imbalance affecting the growth and development, metabolic disturbances and infectious disease like the poliomyelitis, abnormal pressure habits and functional aberration, uh, abnormal sucking like thumb sucking, finger sucking, tongue thrusting, all other habits that can be considered. Abnormal swallowing, speech defects, all are considered in the classification. The local factors could be anomalies of number like missing teeth, supernumerary teeth, or the extra teeth, anomalies of tooth size, shape, and abnormal frenum, premature loss of teeth, prolonged retention of the deciduous teeth, delayed eruption of the permanent teeth, abnormal eruptive pathway, or ankylosis. What is ankylosis? It is the fusion of the tooth root to the jawbone. Dental caries, improper dental restoration, all are the these all are considered in the local factors. The hereditary genetic transmission contributing to malocclusion, congenital anomalies, condition existing at the birth, tooth size anomalies, arch, crowding, abnormalities of tooth shape, all these are considered. The cleft of the lip palate, congenital syphilis. So in the patient with the congenital syphilis, you will see Jensen incisors, mulberry molars, enamel deficiencies, extensive dental decay, anterior crossbite. The maxilla is smaller in size relative to the mandible. These are the features. Maternal rubella infections. Maternal rubella infection during pregnancy is believed to cause congenital malformation in the child. The features that could be seen are these. Other is the congenital conditions like cleidocranial diastosis when there is absence of clavicle bone. The patient exhibit here presence of supernumerary teeth, short and thin roots, over-retained deciduous and retarded permanent teeth. So these all are the features. Other conditions are the cerebral palsy, environmental factors, anomalies in teeth, odontome, missing tooth, congenital absence of teeth. It is known as anodontia or hypodontia if the teeth are missing from the arch. If all teeth are missing, then it is anodontia. If 6 or more permanent teeth are missing, then the term is oligodontia. If 6 or less than permanent teeth are missing, then it is hypodontia. Now the hypodontia, the decreasing order of frequency is the third molar, lateral incisors, second premolar, mandibular incisors, and maxillary second premolar. Other could be anomalies of tooth shape, abnormal labial frenum, premature loss of deciduous teeth, long retention of the deciduous teeth. So these all are the factors that could be related and considered in the etiology of the malocclusion.